You're listening to Going Viral, No One Should Die from Embarrassment, the podcast that explores the conundrum of anal cancer and precancer, a podcast that can save lives. I'm your host, Dr. Eric IANS, anal dysplasia expert and gynecologist.
And I'm your co-host, Mary Jo Murphy, registered nurse, anal cancer survivor, and patient advocate.
We are sponsored by IANS, International Anal Neoplasia Society, the premier society for anal cancer and precancer treatment. This is a podcast for providers, patients, and everyone in the realm of anal cancer and precancer, research, prevention, and treatment. We will interview really cool, smart, interesting people who are international experts in the field.
And we will have deep heart-to-heart conversations with patients, providers, advocates, and everyone in between.
We're going to talk about your bottom and the bottom line. There's a conundrum. Anal cancer is out there and yet it's being missed. We on this podcast are going to fix this. We will help solve the riddle. How do you find a disease that no one's looking for?
You'll hear practical, life-saving information with no shame or judgment that will empower you to speak up and speak out about what concerns you. If you're a patient, tune in to the next 25 minutes. You might be at risk, but you feel embarrassed. Awareness can change your thinking and the course of a disease that's being missed.
If you're a provider, don't miss it. The next 25 minutes are anal cancer. So I want to welcome Dr. Stephen Goldstone to our podcast today. He's not only a colleague of mine, but he's also a very, very dear friend. So just a little bit about him. Dr. Stephen Goldstone is an expert in anal dysplasia, which is anal precancer, diagnosis and treatment. He is the past president of IANS, International Anal Neoplasia Society, one of the primary authors of the Anchor study, which is the premier New England Journal of Medicine article that changed the way we treat anal dysplasia. His specialty is in the LGBT realm, and he has diagnosed and treated thousands of patients with thousands of high-resolution anoscopies and anal treatments. He is the grandfather of our field and has been a trailblazer in research, education, training many of us currently on the ground today and patient care. So let's all welcome Dr. Goldstone today. So how do you prefer to be called? Dr. Goldstone, Stephen, Steve?
Grandpa?
Steve, call me Steve.
Okay. And to be thorough, what are your pronouns? Mine are he, him, and his.
I like those.
You like
he,
those?
him, and his. Yes.
Okay. So I think Mary Jo, you're kind of up on here.
Yeah. So can you tell us how you got into this field?
Okay. What happened was I was a general surgeon and I got involved in ano-rectal surgery. Okay. And as I became more comfortable with my sexuality, I'm obviously now an out gay man, but in my day, you weren't out as a surgeon. That was the kiss of death. But as I became more comfortable with it, and I began to reach out to the gay community, gay men, because a lot of them had horror stories about going to these straight surgeons treated very homophobically. And I might also add that a lot of patients also had a lot of fear of going to doctors, and they felt threatened, and they had internalized homophobia, about their sexual practices. And like you said, completely embarrassed and afraid to admit anything. So I felt like I could be a welcoming caregiver for them, where hopefully they could be honest. And I started doing a lot of anorectal surgery because a lot of gay men had problems down there that were coming to me. And I started getting back these strange pathology reports, when I thought I was removing a wart or a hemorrhoid or something, and it would come back high-grade dysplasia. So I started looking into it, and I found the wonderful people in San Francisco. Joel Palevsky and Naomi J. was a godsend. She taught me all about HRA, then we called it colposcopy, and Michael Berry, and it was great because I came at it from the perspective of treatment. I was a surgeon and they had no idea how to treat that. So we got to work together, and it was a marriage made in medical heaven for me. And that's what happened.
That sounds amazing. That sounds medically and professionally, socially amazing. So how do you see training in our field in the future?
So this is not for everybody, that's for sure. If you're only going to do it once or twice a month, it doesn't pay. You're never going to get good at it. I really see it moving a lot to either clinicians who are completely behind this and enjoy this kind of work, similar to a gynecologist who just focuses on cervical and vulvar dysplasia kind of thing. So I see it evolving that way, and I see advanced practice clinicians like nurse practitioners and PAs really becoming a mainstay in this field as well.
Thank you.
And Naomi is a nurse practitioner whom you spoke of.
Yeah, she's also royalty. She's the Tushy
She
Queen.
is. Yep.
She is the Tushy Queen. She's a nurse practitioner, PhD, actually.
Yeah.
Right.
Yeah.
So I think I'm going to go on to my next question, Mary Jo. Is that okay?
Sure. Go ahead. Yep.
So you've seen more bottoms in New York City than anyone I know. You know,
Are you talking about sexual position or tushies?
I'm actually talking about tushies. What
Okay.
overall advice can you give the average person on anal hygiene, particularly gay men who have had either anal treatment for anal precancer or even radiation for anal cancer? What is your I know there's a lot of questions in this, but what is your recommendation on anal sex for those people? And by the way, didn't you write a book?
I did. The ins and outs of gay sex, a medical handbook for men. You can even get it as an e-reader.
Like I can be reading this on my like Kindle, like
Yes.
on Fire Island or in P Town. I'll be like,
Yes.
okay,
Yes. So you want to hear a funny story?
sure.
Yes.
And then you can tell us about anal hygiene.
Yeah. So when my book came out, there was a big book party launch, and the editor at Dell was very proud of this book, and he really pushed it. And this straight woman came up to me to sign the book. She was buying it. And I said to her, I knew her, I said, "You don't have to buy this book." She said, "I got to tell you, I'm sick and tired of dating one gorgeous guy after another, only to find out down the road that they're gay. So I'm keeping this book on my bedside. And if I catch any guy looking at it, he's out." So I thought that was funny. All right, so I'm going to take the easy one first, which is post-radiation chemo for anal cancer. I do not recommend anal sex going forward. Yeah, unless they have a really, really good sphincter, don't have a lot of scarring or something like that, I usually tell them be very careful, because what radiation is the gift that keeps on giving. That's what I keep saying. So what you have today can end up being worse in 10 years. So the sphincter muscles can undergo fibrosis and become less than functional. And some people actually, especially that extensive disease, their sphincter muscles can be destroyed, first by the cancer, then by the radiation. And then they really depend on like anal scarring to maintain a degree of continence where they're not losing their stool and gas. And then if they're bottoming, it can really stretch it out. So I tell them that it's not something I recommend because it can lead to problems. I know there are patients that I have who have great results from radiation, And not because the radiation oncologist was better. It's just depends on how much high grade they had, how big the tumor was. So, you know, and I know some of them do have anal sex, but I caution them. So that's what I would say about that. As far as going into regular receptive anal sex, bottoming, as people like to say, I think that one of the things that gay men do is they can be quite abusive to their bodies with a clean out, with enemas or a shower hose up there. And that can cause a lot of problems in that it ends up loosening the lining of the rectum from the muscular layer because of the pressure going in and then the pressure coming out of the water. And they can end up with issues related to prolapse and inflammation. We call it proctitis. It's not an STD, but the area is inflamed. And
that would be a
so
non-infectious proctitis. Am I correct on that?
exactly.
Okay.
Yeah. It's an inflammation, inflammatory. So look, I tell people if you can avoid cleaning out, that's great. If you really feel you have to, then like one empty Fleets bottle with plain water, very gently insert it, and not a lot of high pressure squirting. And because, you know, I have people who, oh, I just use a little Fleets to clean out. And I said, well, how many do you use? Oh, 10, you know, till it's, no. And so, and they end up having ulcers and tears and things like that. And I tell them lots of lube. Spit is not a good lubricant. And I say the best thing to do is to control penetration. Most people who have been treated for anal dysplasia have no trouble having anal sex again.
But, you know, I mean, this is going to be difficult for the porn industry if you really had to. I mean, not that this is a place to discuss this, but can you just, you know, explain what does it mean for a person,
Okay.
a person to
Yeah,
clean their
no,
body?
that's a really good question. So, what I say in my book, it's an asshole. It's always going to be an asshole, no matter how you try to pretty it up. Okay. So, the point is, I see another thing. A lot of people wipe and wipe and wipe and wipe. And the toilet paper is extremely abrasive. Or some people cover their finger with toilet paper and actually stick their finger inside their tush and try to pull out any residual feces and they tear themselves. Uh, or they think just because I'm using like wet wipes or something like that, that I can use a lot of them. Well, the problem is you can't because it's very irritating down there, and you cause these microabrasions and inflammation, and it itches like hell. And then they just think they have to get it even cleaner because they're itching. It must be because of feces. So I tell them when they're done pooping to immediately get off the toilet into a shower and bend over and with plain water and their fingers gently massage their anal opening. That will remove any fecal residue and then pat it dry. Absolutely no soap. Soap is very dry. So this is what I tell them to do. If they can't get into a shower, a lot of people now buy these washlets for their toilet. You
Like
can
a
get the,
bidet.
yeah, but you know, it's made for your tushy, you know, and they use that. Other people, I tell them if you can't get in the shower, you know, then you're allowed to use like Tux. It's a medicated pad with witch hazel, but you're only allowed 2 wipes. One gently up, one gently down, throw it away. I'd rather they stain their underwear than wipe the hell out of their tush.
Interesting. Very
Yeah.
interesting.
And no hair removals. As far as like the creams, they're extremely caustic around the anus, you know?
Wow.
Mm.
Very, very interesting. So I'm sure this is going to be very helpful to all those people out there that do, any kind of anal, I don't know, extra things that they do. So I think the next thing is I'm going to hand it off to Mary Jo, because I think you have some great questions yourself here.
I hope. I
So,
actually,
but can I just say, Mary Jo,
sure,
as like a cancer survivor kind of thing, this is also the way to treat your tushy after radiation,
exactly. Yep.
very gently.
Yep. Yep. And there is, I guess there are some studies, or there was a study about wiping and transmitting the HPV virus by being um, too vigorous with the wiping.
Well, you cause microabrasions.
Exactly. And
Sometimes you
that
cause
with
real
women
abrasions.
too. Yeah, with
Right,
women too. Exactly.
right.
Yeah, I'm actually we bought some of those. It's like a bidet, but it's just a squirt thing
Right, right,
that
right,
I
right.
learned about when I was in Brazil, and oh my goodness, it makes life so much
Yeah,
simpler.
one of my patients who has anal cancer, sadly, was telling me that he got the attachment to the toilet during radiation because he couldn't touch his bottom
Yeah.
there. And it totally, brought him some peace to
Hmm.
try to keep clean.
Yeah.
Mm,
Yeah.
mm.
So I know exactly why your patients feel so comfortable with you, and I just wanted to comment that the people that I've talked to who you take care of love you, and
Well, thank you.
and I think it's probably what you just said about how you talk to them, but this is women too.
Yes,
So
sure.
yeah,
I
so
don't mind talking to women.
yeah. Well, they like talking to you too. but
Right.
but I just I probably can elaborate if you'd like a little bit more about what it is that you do to make people feel so comfortable.
I like to talk to them before I ever see them in an exam room if they're a new patient,
Hmm.
to establish a rapport. They're not in a gown, scared out of their mind that I'm going to hurt them. Uh, and then I bring them in and get them undressed. I 100% set up boundaries. Like, you have to put the gown on when you get undressed. And I always have an assistant in the room,
Hmm.
you know. Um, and I tell them exactly what I'm doing. I think you have to be mindful of the patient's reactions, what they're doing, like I've had patients in there who never gave you a history of sexual abuse, but when you try to start doing the exam, you see what's going on.
Yeah.
Uh, I think treating them with respect. And I like to say that if someone tells you something and you don't know what they're talking about, ask them,
Yeah.
kind of thing,
Yeah.
and try not to be pejorative, I guess,
Yeah. Yeah.
you know.
Well, it works because how you deal with patients is appreciated, I think.
I also tell them like it is. I don't like, so if I have a patient with newly diagnosed anal cancer, I tell them they need treatment, that the overwhelming likelihood is they will be cured, but it will be the worst thing they've ever gone through in their life.
Hmm.
Because people try to minimize it,
Yeah.
and like, oh, it's just like 5 minutes on a table, flicking a light switch, and it's set. I tell them, you be good to yourself, you take a leave of absence from work,
Mhm.
and a lot of them think I'm nuts for the first week or two.
Yeah.
And then it's like, the fatigue and all the, so I find it's always best like that.
Yeah. And then talking about maybe what some alternatives are, or what exactly is going to happen, and what they can expect, and so they can make choices about what, not necessarily whether they're going to be treated, but
Well, some do make that choice. I just
Yeah.
want it removed or whatever.
Yeah, exactly. Okay.
I think so I have actually a question. It's so funny that we had to create through IANS to create a podcast about, to make awareness about the butt or awareness about the anus. And it seems that our society across the world has such a hard time talking about these words, the butt and the anus. I personally feel it has contributed to people dying from this cancer. How do you think we can get past this as a society? I mean, why is it? I mean, you don't have to go into detail about this, but I mean, how can we overcome this shame about the butt and the anus and all that is around it?
Well, I think it's 50-50 or maybe 60-30, where the problem is the patient. For a lot of people, I think what I see is people, and we see it in everything, whether it's a breast lump or a skin mole, so many of them are always trying to explain it away, like, oh, I've got my period, so my breast is swollen. When in reality, it's a mass there, or this mole has been there, I must have banged my leg. It's the same thing on the butt, it's like, I'm sure it's a hemorrhoid. Or I asked my friend, yeah, they every now and then get blood on the toilet paper, instead of going to the doctor because they're embarrassed. And also, there's no reason going to a doctor who makes you feel shame. There are enough people out there. And I tell patients, why didn't you ask your friends? It turns out if you mention a butt problem, almost everybody at the cocktail party will have had an experience, and told you about who's good, who's not, or whatever. So that's why I say part of it's the patients. When I started doing this, and I don't know, Eric is a gynecologist, maybe you can appreciate it too. When I started asking sexual history questions, like really probing about what their practices are, etc., some of them were actually quite offended and thought I was really prying, and I said, no, I need to know what's going on, what your risks are. So I think, we have to take ourselves seriously. And then the other problem is physicians, one that may not be comfortable treating this or want to treat this, or with the patient population that they may be seeing, kind of thing. And the other, and not knowing. But the thing that I see is so much now. Look, I'm a big proponent of telemedicine, but I see people who are, they tell their doctor, I have some bleeding. They don't get an exam. They get a prescription for a suppository and treat it for hemorrhoids.
It's so true. As a educator for OBGYN residents, there's this imaginary line on the perineum, which is the area between the vagina and the anus, for those who don't know what that is. And it's so funny that there's this imaginary line where where these gynecology residents feel like they just will not go below. I'm like, you have to do a rectal exam. Oh, she doesn't need one. What do you mean she doesn't need one? Oh, it's uncomfortable. Or every excuse not to do a digitally anal rectal exam.
Right.
Every excuse.
But how many times do we get a call from a patient, maybe I had vigorous sex and there was a little blood. Oh, use more lubricant, whatever kind of thing. Or, we so often, we can dismiss a complaint, and then the patient can end up feeling embarrassed that, oh, I bothered them, So, I mean, if you're going to dispense advice like that over the phone, it's fine, but you make the point of saying, if it doesn't get better or keeps happening, you must come in.
I think that's absolutely correct. I think I'm, not to be the bearer of bad news, but I am looking at our stopwatch clock here. And we can certainly talk forever. And unfortunately, because of time, we do have to end
Can I
our
say something though?
absolutely for you, anything.
Okay. I think the opposite is also true. I have seen a lot of people who've been treated for warts with creams or, like imiquimod or whatever they're being treated with, and no one has taken a look.
Mm.
And it may not be a wart, or the person's been treated for one recurrence after another with getting them zapped, whether it's a dermatologist or whatever, and it's not a wart either. It's like a papilloma or scar. So if you're going to take something off the butt, and you should before you start treating it, make sure you send it for a biopsy. Make sure you ask your doctor to get a biopsy of it. Warts go away. It isn't like you should be treated for 3 years on imiquimod and still having the problem kind of thing.
Mhm.
I think that's excellent, excellent advice. And I do really appreciate that. I also, as a physician in this field, feel that that's wonderful advice to give to patients and to providers. So
And
thank you.
patients need to ask to be touched, to be examined. If somebody is blowing you off and saying, "Oh, I know what it is," and you're worried, keep looking until you find somebody who'll pay attention.
Right, right. Although I have to say, sometimes reassurance is a treatment, like
Yeah.
telling a patient,
Yeah.
you know?
Yeah.
So we do have to end the conversation. And so Mary Jo and I want to thank you for all the work you do in the field of anal dysplasia and anal cancer and for sharing this with us and our audience today. So thank you, Steve, Dr. Goldstone, Stephen, and all those words. So
Grandpa.
for grandfather, grandpa. So for those on the podcast, Mary Jo and I want to share how to get involved with IANS, International Anal Neoplasia Society, as a patient or as a provider. Please go to www.iansociety.org. This is 1S, www.iansociety.org for more information. And we thank you again for listening to us.